Yeah, we can see, sir.
Fantastic.
So maybe after the session, also we'll have a telephonic conversation, sir.
Sure.
So
Definitely.
you may be doing for 1 hour, sir, like 1 to 2 o'clock. So then after that, another person also will join at 2 o'clock.
Okay. Yeah, no worries. I don't know if I need 1 full hour, but
You can take the
right.
questions also.
Yeah, of
during
course.
Q&A.
Yeah, definitely.
Like initially few minutes introductions and other things, then we'll continue. Then you can have more questions. I think that maybe it's okay.
Yeah, definitely.
First of all, thank you for.
Still see the presentation, right?
Sorry, sir.
You can still see the presentation, right?
Yeah. Yes,
Okay.
yes, we can. Yes.
Okay, fantastic. A lot of times, what happens is I go keep talking and then I forget to share or something, and some other
Yeah.
window is showing or something like that.
And also, generally, people may ask, "Can you share your presentation?" So
Yeah, there's nothing secret here. So,
yeah. Now, later on, you can send to us, so that send to me, and then I'll send to all of them together.
Yeah, definitely.
Because some people have their own classes also. They will share with them this presentation.
Sure.
And also will share them the recorded session also. So that's how it goes, sir.
Yeah, no worries.
So as it's 1 o'clock, I think we can start the session.
Sir, I'm ready whenever you are.
Yeah, we'll start. It's 1 o'clock. We'll start the session. All to our MCs, we can start.
All clear for me or?
Yeah, it's clear. So my team, they will just introduce you, then you can start.
Got it. Okay.
Good afternoon, everyone. I warmly welcome you all to this insightful session of our Faculty Development Program organized by the Department of Artificial Intelligence and Data Science, Jyothi Engineering College, Cheruduruthi. We are now moving into a very important and forward-looking topic in the domain of public health and artificial intelligence. Today's session is titled Predict, Prevent, Protect, from episodic systems to continuous intelligence in public health. This session will focus on how AI is transforming public health systems from reactive approaches to proactive and continuous intelligence-driven models, enabling better prediction, prevention, and protection of communities. It is my great pleasure to introduce our distinguished speaker, Mr. Sridham Puthukuchi, founder and CEO of PinTheory.ai USA. Mr. Sriram is a global executive and thought leader with over 27 years of leadership experience in data, artificial intelligence, enterprise technology, and business transformation. He has successfully built and led large-scale data and analytics organizations across diverse sectors, including healthcare, financial services, logistics, retail, and public sector, delivering impactful and measurable outcomes. As the founder and CEO of SpinTheory.ai, he advises boards, governments, and enterprise leaders on AI-driven transformation, helping organizations convert complex data into strategic advantage, operational efficiency, and sustainable growth. He is known for his practical and result-oriented approach of aligning strategy, governance, and intelligence systems to drive real-world impact. We are truly honored to have such a visionary leader with us today. Now, without further delay, I invite Mr. Sriram Puthukuchi to take over the session. Sir, the virtual stage is yours.
Thank you so much, Reshma. Good morning, good afternoon, good evening, depending on where you are. Today, I want to talk about something that I believe is at the core of challenges we are seeing in public health today. So the theme today, I was thinking about what the theme could be, and there is a lot of work we're doing on preventive care using AI orchestration models and data-driven thinking. That I thought it's an apt for this forum. And but most importantly, this is about moving from episodic systems, which is the current state of the healthcare systems, to perhaps something that is more continuous intelligence. And this is not just about a technology or improving efficiency, it's about fundamentally rethinking how our health systems are currently designed. And what I will share with you today is based on observations and work we have been doing in different healthcare settings across the world, hospitals, public health initiatives, and a consistent pattern emerges in all of them, right? So, one second, if my clicker
അവിടെ
works.
എഴുതി കൊടുത്താൽ മതി.
Okay. So,
മിസ്സേ, ഒരാൾ കൊടുത്തത് സീനിയേഴ്സ് വെച്ചിട്ട് നോക്കുകയാണെങ്കിൽ നമ്മളെക്കാൾ ഇപ്പൊ ഞാൻ ഒരു സബ്ജക്ട് കൊടുത്തു,
We're
അതിന്
seeing
ജിക്കെ സാർ കൊടുത്തു, ജിക്കെ സാറിനായിരിക്കും
some
പ്രിഫറൻസ്.
feedback.
തിയറി 1 തിയറി 1, തിയറി 1, തിയറി 2, തിയറി 3, 3 തിയറി ഉണ്ടല്ലോ. തിയറി 1 ഞാൻ
Please, Akshara, please unmute. Please
ഡീപ്
mute
ലേണിംഗ്
it.
കൊടുത്തു, സീനിയർ സാറിന് ഡീപ് ലേണിംഗ് കൊടുത്തു.
Some crosstalk, some feedback. Okay, so the core question. Let me start with a simple but a very key question, right? Across countries and systems, what we are seeing is increasing healthcare budgets annually and expansion of infrastructure. You know, hospitals are constructing new infrastructure and whatnot, and more programs and interventions. And one thing that is consistent yet is that we are continuing to struggle with rising chronic disease and increasing hospital admissions and a lot of late stage interventions. So the question is, why is it that with all that's being done, we're not fundamentally changing the outcomes? The outcomes seem to not favor all the investments and infrastructure and that everything that's going on across the world. And this is across the world. And as you can see, these are some of the stats that we pulled up, and these are well published. Indian Council of Medical Research, World Health Organization, American Medical Association, all of that. So we pulled up some of these numbers. So why is that, right? And NCDs are not, I say here, NCDs are not episodic, they're chronic, cumulative, and our health systems are more episodic in focus. And that takes me to the scale of the problem, right? And it is worth reflecting on the scale of the problem. And it's not just a healthcare issue, it's an economic one. And there have been a lot of studies and publications that have been done on what is the potential economic impact. And as you can see, the numbers are staggering. For example, cardiovascular disease alone is estimated, not expected, to cost around $1 trillion annually in global economic burden. Right? This is direct and indirect costs. The wage loss, the productivity loss, the wage loss for the family, the productivity loss for the employer, direct healthcare costs, and whatnot. So, non-communicable diseases account for around 70%, roughly 70, 3/4 of global deaths annually, right? And 20 million, over 20 million deaths due to cardiovascular disease alone. And this is in many settings, conditions like hypertension are undiagnosed, right? And so this is just not a clinical issue, right? It's a systemic and economic issue that affects productivity, like I said, household finances and long-term growth. So that is, I just wanted to throw some numbers to show that this is not just a healthcare issue. It's an economic one for states and for the country, right? And another example I cite here is the NCD burden on India. Very conservatively, about 5.8% of GDP is the cost of the NCD burden to the GDP of India. And that translates to about $170 billion a year. And that is very conservative estimate. And general estimates say it's anywhere from 5 to 10% of GDP is the impact of the NCD burden on any economy. And that's well published out there. And southern states, as you may know, southern states in India carry disproportionately high burden of NCD. So moving on, the control gap, right? So where current systems fall short. And when you look closely at how health systems are structured, whether at the state level or within hospital systems, you begin to see a consistent pattern. A large portion of resources are directed towards tertiary care, managing complications and late-stage treatments. And this is relatively less structural investment in early detection, continuous monitoring, and prevention mechanisms. So what happens in practice is that systems become very good at treating advanced diseases, but not at preventing its progression, right? In effect, we are optimizing for cost absorption to the system.
എന്ത് അഭിയുണ്ടോ അഭി വരുന്നുണ്ടോ എവിടെ ഇരിക്കുന്നുള്ള ആലോചിക്കുന്നു.
The admin, please mute others.
So in effect, what is being done is we're optimizing for cost absorption in the systems, not cost reduction, right? And that's a structural design flaw. We have the knowledge and the tools. The challenge is the sustained engagement or lack thereof. That is sort of the theme. So we go to evidence from the systems, right? And then we look through how we have looked through how states allocate their budgets and where the money is allocated and all that. And we've looked at multiple states, Indian states' budgets, and disproportionate amount goes to tertiary care, 65 to 70%, and very, very less is allocated to preventive care. And one of the states, one of the southern states, the allocation is less than 1%, right? And when you look at World Health Organization's best practices, recommends 15%. Now 15% may be a little over the top, but anything closer to 15%, right? A lot of states have less than 1% in preventive care, and that is not structured to be preventive in nature. That is more reactive in nature, right? And I say here, cost concentration of Kerala. Top 10% patients consume about 67% of the insurance pool, right? And 35% year-over-year increase in cardiac procedures. So these numbers are staggering, and the systems are designed to be more reactive than preventive, right? And I list hospital burden and readmission rate and whatnot just to highlight my point. Moving on, a fascinating structural observation, right? Is that chronic diseases or long-term, they're cumulative and whatnot, and the budget cycles are annual. And typical patient touch points are 3 times a year, if that in some cases, versus 365 days of progression of chronic disease, right? Sorry, I lost my presentation. 1 second. Can you still see my presentation?
Yes, sir. Yes, sir. We can see.
Okay. I lost the presentation here. Sorry. Where was I? The control gap. Sorry, give me 1 second. Yeah, I was here at the fascinating structural observation, and the research opportunities. Can we redesign the system around continuous engagement rather than episodic clinical encounters, right? And two major trajectories of clinical comparison, what the literature shows about risk progression, right? So on one side, I have an episodic pattern, and on the other side, I have a longitudinal pattern, right? And where the touch points are more frequent, visible risk trajectory tracking, early signal detection, and proactive therapeutic intensification, and outcomes-based, more sustained control, and episodic event prevention is the goal. And for episodic pattern, the reactive management, hospital-based interventions, and all that is sort of the focus. And I say that here, the higher continuity of care associated with reduced hospitalizations, and there have been some studies that have been done and well publicized, as I state here, 16 out of 18 studies say higher continuity of care.
Sriram sir?
Yeah.
Sir, can you please put the PPT in presentation mode?
I thought it's in better.
Yes, sir. Now it's okay.
Is it better now?
Yes, sir. Yes, sir. Again,
What's that?
again, just
No, sir, again, not the presentation mode.
presentation mode. Yeah, this is correct.
Correct.
Now it's okay. Now it's okay.
Okay. Sorry. So moving on. 1 second. I'm just. So here I say understanding the disease progression dynamics, right? And this is the same theme, right? And I just show some current reality and control rates and all of that, and I don't need to explain this to this audience. And the theme here is the earlier we engage, the greater the leverage is, right? And the cost architecture, right? So these are observed patterns across multiple healthcare systems, and generally the 5%, top 5% of the patients amount for the more sicker patients, if you will, attribute to 40 to 50% of the total costs, and this is consistent finding across multiple healthcare systems. And top 10% account for 60 to 70% of expenditure. Indian insurance, UAE we looked at, US Medicare system we looked at. It's generally, few numbers here and there, but it's consistent. Those numbers are very consistent across the board. As you know, post-event cardiac care costs around 5 to 8 lakhs per episode. Pre-event monitoring is generally much cheaper and that sort of thing. And intervention economics well published is around 40 to 60 times cost differential in favor of preventive versus episodic care. So that's a prevention leverage point, right? It's the economics also favor the sort of the focus on prevention. And what if we measured momentum, not just the state, right? So traditional metrics, access to healthcare, utilization, mortality, outcomes, and quality, right? And stability metrics, and I wrote a piece on the missing metric in global chronic disease, is the stability metrics. And stability metrics like what is the population risk distribution over time, and what is the trajectory look like, and risk tier migration velocity, meaning, low risk to medium risk, mediumness to high risk to extremely high risk. What is the risk tier migration velocity, and what does it look like? And what is the control stability look like? So these are the metrics that are designed to measure stability rather than episodes or more of a reactive design. And here I show, this is very busy, but here is the I wrote a piece on, like I said, the missing metric in global chronic disease. In this thing is the stability metrics. This is where we look at, the population, and this is generally, this applies to many different systems and settings. Generally 2 to 3% minimal risk. I'm sorry, 45% to 55% of the population, minimal risk, account for 2 to 3% of the costs to the healthcare system. And as you go down from minimal risk all the way to the inverted pyramid, I guess, the top of the pyramid inverted, the severe 1 to 2% of the population that have a severe condition account for about 25 to 35% of the costs to the system, healthcare system. And as you can see, it's very disproportionately skewed towards, if you look at the top, tier 4, 5, and 6, it accounts to majority of the cost to the system, 60, 70%, upwards of 60, 70% to the system. And when I talked about the metric moving between the risk tiers metric, is, I guess, the magic, and there's no magic bullet, but I guess the key to it is the migration between these tiers is the key. And if that stability can be measured across these tiers, that is where there may be an opportunity for the preventive care, right? And we looked at risk tier transition. Each tier transition adds how much more money per patient annually, right? And the system signal is really the movement between these tiers, from low risk to medium risk to high risk and all that. And the episodic care is more of something happens and something happens, and there is nothing between the two episodes. And this continuous intelligence, continuous way of thinking, basically finds opportunities between two episodes, and finds opportunities where this can be optimized and perhaps prevented or delayed in some cases. So what actually drives costs, right? Like I said, we look through this not just from a healthcare perspective, but also from an economic one. And it's this disease, NCD disease burden is both, is economic one and also a healthcare burden. And health system cost is function of instability, not volume, right? Instability as with events, with episodes. And what it's not is total number of patients enrolled, population size, number of primary care visits, routine screen volumes, right? But the cost is a direct function of migration into high-risk tiers, because as we looked at the previous slide, the cost disproportionately increases as the population falls into medium to extremely high risk, and the velocity of the tier progression, right? And 1% of population shift upwards. Well, I had a inverted pyramid, so I guess it's downwards. It amounts to 8 to 12% of cost increase. 1% of population shift towards medium, high, and extremely high risk is 8 to 12% of cost increase. So that's significant. That's 8 to 12 times more money for each 1% of shift downwards, I guess, because I had an inverted pyramid. And each stability failure is 5 to 8 lakhs worth of event cost if there is an episode That's on average, it is 5 to 8 lakhs of event cost. And what the evidence reveals, right? Medication adherence for chronic disease, 50% globally, higher continuity, and this is done by a few studies across the world, as well, India, US, and parts of Europe and South Africa as well. Therapeutic intensification, and financing patterns, NCDs receive 1 to 2% of global health investment. And the financial patterns don't favor the preventive aspect of this burden, of this disease burden. So adherence may be structural than behavioral, right? And lifestyle is a big aspect of NCD burden, but there is also structural aspects that are also part of it. And our systems, healthcare systems, are not designed to handle continuous intelligence or continuous care. They're designed to handle episodes very, very efficiently. Fantastic job of handling episodes, but very, very few systems are designed to handle the continuous intelligence, and that is probably the structural gap that exists. And the opportunity lies in redesigning engagement frequency and probably feedback loops. And this is probably oversimplifying the complexity. But what I'm trying to impress upon is that structural deficiencies exist. And they're not designed to handle the continuous engagement and continuous intelligence that will hopefully delay and or prevent cardiovascular disease or NCDs at large. So that's the point here. So from episodic, so how do we, how should we think about going from episodic to continuous intelligence, right? Current model, episodic engagement, event-triggered care, cross-sectional data, reactive protocols, and facility-centered, right? And a proposed model could be continuous monitoring where applicable, always on risk sensing, longitudinal cohorts, predictive algorithms, and this is perhaps where the AI will come into play, and more population centered than a facility centered, and the core elements is real time risk tracking across populations, and the real time has to be taken with a sort of a grain of salt, in terms of focusing on more sicker of the population groups, and perhaps predictive modeling and a more timely predictive modeling and preemptive interventions and triggers and stability as primary outcome metric, and not events, that sort of thing. So moving on, I call this prevent, predict, and protect, the 3P framework. Universal population screening, risk factor detection, prevent, early intervention at pre-disease stage, target 80% plus screening coverage. Predict AI-based risk score modeling, trajectory modeling, real-time analytics, and prioritize high-risk patients, right? And I've looked at a few healthcare systems, and the prioritization generally doesn't happen with high-risk patients. Generally, there's a population, and I've analyzed only a few healthcare systems and healthcare workers and what they do and that sort of thing. In the limited systems that I've analyzed and observed, the prioritization doesn't happen, right? The screenings and checkings happen at the patient's home or local facility and whatnot, but the prioritization doesn't happen. That those screenings happen more of an egalitarian manner, more of a unprioritized manner, and not prioritized based on the highest risk patients. So that may be an opportunity. Is some of the systems we have seen that may be an opportunity where higher priority might be given to the more riskier patient lot. And protect continuous remote monitoring, proactive intervention, behavioral support, adherence coaching, and closed loop feedback and adjustment. And I realize that these are very, very easier said than done. But definitely, it makes a lot of sense to at least go in this direction, because research says if this is coordinated well, and if this is done well, it could work. So what changes structurally? What changes between the current and continuous intelligence, right? Event triggered. So some event happens and then current system, something triggers. And continuous intelligence is always on, meaning the risk modeling of I don't want to say patients, but citizens, right? The goal is prevention. So some form of risk modeling with a set population group is always on, right? And based on the new data that's coming in, based on what the models are learning as we go, and based on other data that's coming in about the population group, the continuous intelligence is always on, even between episodes, to two medical episodes, the continuous intelligence is on, right? And the current system is, like I said, hospital centric, and continuous intelligence is how do we make the population healthier, more population centric. And the current system, more static data, what happened yesterday, what happened last month, what happened in the past. And continuous intelligence is dynamic signals based on the data that's coming in constantly. Dynamic signals on how the risk stratification changed and which group of citizens moved from one risk stratification to the other risk category, right? Things like that. And current systems are reactive, and continuous intelligence gives us the ability to at least predict to some extent. Now, it's not going to be 100% accurate prediction, but it's better than the reactive current system of reactive approach, right? And the model will get better and better the more information we give it, the more context, the more references we give it, the model can only get better over time. That'll allow the continuous intelligence to be worth the effort. So I say CVD prevention opportunity, what the clinical evidence shows, right? These are some of the stats that are well published. 1.4 billion adults have with hypertension globally, only 21% are controlled. Clinical evidence shows, 20% CV events, and prevention window, 70 to 80% of first heart attacks preventable with early BP control. Now, some of this we talked about earlier in earlier slides is that, a lot of this is lifestyle for sure, but that continuous orchestration and continuous intelligence is also missing. And structurally, the systems are not equipped to handle continuous intelligence. They're not designed to handle continuous intelligence. Some systems do have it. I'm not talking about every system, but most systems are designed to handle episodic care, right? And I just say the earlier we engage in the natural history, the greater the leverage we have in preventing and or delaying. This is based on studies that have been done across the world. And what we measure, and we talked through this, earlier in a different format, but some of the examples, admissions, traditional admissions, mortality, coverage, utilization, on the stability, we measure risk, the migration velocity, like I talked about, control rates, stability index, preventable events, what events were avoided, what events, were delayed, and what is the cost per stable patient, right? And that's a very important metric to measure. And the cost per stable patient is going to be much lower to the system than otherwise. So the economic case of prevention, again, I talked through this and we went through this a few times, right? I talked through this and Indian state level opportunities. And I impress upon the fact that this is an economic intervention as well, not just a healthcare one. And if you see this, Indian state level opportunity of 8,000 to 12,000 crores annual value. This is based on, if you look at, earlier I said 5.8% is, 5% is on the conservative side, economic burden of NCD disease on Indian state, right? That is very, very conservative, 5%. Generally, the range is 5 to 10%. And for example, if you take a state like one of the southern states, around 13 lakh crores is the state's economy. And if you take 5% of that, the disease burden of NCD amounts to around 60,000 plus crores every year. That is lost productivity, lost wages, lost employer productivity, direct costs, and then whatnot. That is a significant burden, right? And what I say here is an opportunity is that even if there is a 5% improvement in what we're talking about here, which is continuous intelligence and preventive, it amounts to big money, 8,000 to 12, perhaps 12,000 crores of money that goes back into productive economy, right? And I just one example to show that, and we have been discussing this with a few state governments in South India, and also a couple of provinces in South Africa on preventive care, not only from a healthcare perspective, but also from an economic one, because even if the impact is 1%, it is still it adds up, not just from a financial standpoint, but also from a healthcare standpoint as well, right? So why now, right? And a few things, right? There is a good alignment of few things that makes it worthwhile to do it now, right? The risk AI and ML, as we keep hearing, right? The risk models, the predictive models are getting better and better and better, right? And reasonably 75 to 85% of accuracy can be achieved over time. It's not going to happen on day one, but over time, with given the right information, given the right context, given the right engineering and what have you, that can be achieved now, right? There's digital infrastructure now, and I name a few things that are available. UAE, we're working with UAE as well, and India, and there are a lot of electronic health record systems now in each state that makes it possible to access that information and turning it into meaningful actions that will help with the outcomes. And accessible devices, right? Now, medical devices are getting more compact and cheaper and are able to are accessible to even rural areas in a lot of cases. And the smartphone penetration, the smartwatches and the smartphone penetration makes it possible to collect information, good data that is reliable. And connectivity, right? So there is 4G, 5G enabling network for the most part, and that makes it accessible. That makes population at scale accessible. And policy momentum, right? So there's policy momentum is there across multiple states. There are several healthcare initiatives that they're doing more screening, digitizing the health records and whatnot. And what this preventive intelligence does is it can use all that information, if designed right, to deliver better outcomes, right? And I say evidence-based. There are 50 successful pilots documented globally. Some have gone beyond pilots, but still, it's not been achieved at this. It has not been deployed at scale because, a few things. One is it's not easy. It's definitely not, it's easier said than done. But I do think that with everything that is available now, and all that, I think that it makes a lot of financial, and also from a public health standpoint, it makes a lot of sense to at least attempt it, because even 1 or 2% dent in the current trajectory can make a huge difference, significant difference to the public health and the general economy. So policy prerequisites are in place. A lot of states, and even at the national level in India, there's policy prerequisites and technical prerequisites, and healthcare privacy and health information privacy and whatnot is in place. So it makes it a good time to do something like this. So implications, for hospital medicine, observed benefits in integrated systems. Hopefully, 15-20% reduction in preventable emergency admissions, better clinical case mix, more planned, less crisis oriented, improved resource efficiency and capacity management, patients presenting earlier in the disease course, better surgical outcomes, and long-term financial sustainability through prevention, right? It's not a loss. What we are saying is that this could be economically feasible for the hospital systems as well. And we have been working with a few hospitals to show them why preventive care is also economically feasible. And it doesn't have to be, when we talk about preventive, I think the first instinct is that then the incidence will go down, meaning the revenue potentially of the hospital might go down. What we're able to show to a few hospitals in India and South Africa is that it is an economically viable option to take this and still be profitable. So paradigm evolution, traditional excellence, and I think emerging capability. We talked through this in different slides, and I will just go on. So in summary, we have the clinical knowledge, we have the technology, we have the evidence base, and what we are building is a new measurement and engagement architecture for population health. And that is what we're doing, and it requires a rethinking of the design itself and the structural incentives. And with that, I conclude my presentation. Prevent, predict, and protect. Building the future of continuous population health management, and that's it.
So we'll take questions from the audience, or maybe if anything is there in the chat box.
Thank you, sir, for that highly insightful and thought-provoking session. We will now open the floor for a brief interaction. Participants, if you have any questions, kindly post them in the chat box.
Hi, Shriram. This is Dr. Chana. So that was an excellent presentation. How exactly is your system is helping? Can you give some kind of examples? How exactly your AI with the system that you have created is able to show on outcomes? Thank you.
Yes, sir. So, a few things, right? One is um, the key is collecting data at the right time, right? So, for example, like I said, the frequency of screening generally from the at least the system that I've seen and analyzed is the same. It doesn't prioritize a high risk population and whatnot in a few settings in rural and whatnot. So one is the information collection frequency is it becomes critical once we identify the risk, right? So then once we take in the information, we risk score, right? We do risk stratification based on a lot of factors, and not just the basic data, but also longitudinal data as well, the risk profiling, and we take in other data as well, and do the risk stratification, and we based on that, there is very specific suggested, obviously I should say suggested, um, AI recommended intervention. And we are actually building that in working with a few hospitals on not only collection, but also very specifically suggested AI suggested intervention for either the healthcare worker or the hospital or both. And that becomes sort of that learns itself and becomes better and better and better. And one of the things we were able to, one of the hospital we were working with also wanted some sort of gamification to provide some incentive of engagement with the patient. Have you taken, so one of the things that this hospital asked is that can we incentivize patients, like, have you taken, I'm just again simplifying it. I'm not allowed to go into details because of NDA with the hospital and whatnot, but I'm simplifying it. Like, have you taken the medicine today? Yes. Oh, fantastic. Congratulations. You win 100 points or something like that, right? So there are some interventions that we're doing very creatively. And this is just a very dumbed down example. We have very complex things we're doing as well to engage with the group in a lot of different ways based on which risk category they belong to. And that AI model that we are building is taking into account their own data and what worked and what didn't work and what is likely to work within their system. And then we're designing things that will allow that continuous engagement with the citizen group in a lot of different ways. And that is one small example. But we're doing a lot of other things as well with, wearables and whatnot as well, right? So that is sort of orchestration is the key. This is not, and like I say, right, AI is not a magic. Orchestration is the key, and risk scoring, orchestration, and collecting the right data and providing it the context is sort of where all the magic sauce is.
Thank you, sir. Any other questions?
So I see a question from Mr. Yogesh here. What is the accuracy of predictive AI in detecting diseases? I mean, there are, I think that I don't think there is a number per se, right? Like I said, 75 to 85 is generally the number, but it is different for different types of settings. Like, for example, the electronic health records, X-rays and what have you, CT scans and what have you. There's a well-published this thing from Stanford, I believe, Stanford or somewhere, I can't remember, but that says it's able to predict around 86, 87% accuracy and something like that, right? And different settings, it's different. And the prediction is that what we are talking about here is that with all these factors, all this longitudinal data and all the other factors that play into lifestyle and whatnot, we can risk score a patient or a citizen, I should say, because we're talking prevention, citizen, and say this person might be at risk of going between the tiers from medium risk to high risk or something like that, in a more timely manner rather than reacting at episodes or when when it's too late or something like that, right? So that's what we're talking about here. And like I said, anywhere from, depending on models and whatnot, 75, 85 is generally most accepted range of what is achievable. Yeah, absolutely. Accuracy, precision, recall, sensitivity, I think Parameshwari, I think, yeah, that can be used to predict disease. Yeah, absolutely. I was trying to not get too technical, so that's why how do you see the role of doctors changing in the future? Will AI act as a replacement or just a supportive tool for medical professionals? I think AI will be just a support, right? So I think it'll allow physicians, it'll allow doctors to focus on what doctors are good at, which is care, and all the administrative things, taking a lot of notes and searching for information and whatnot, now can be reliably automated with AI. For example, cognitive search is something that we're working on, which is answers to questions, right? You may have a lot of questions and you need to search through information and whatnot. And cognitive search is sort of a internal search within the hospital systems to give you an answer, not a paragraph like a chat GPT does, but an answer. You're looking for something, a very specific answer. What interventions are most effective across my, I don't know, 16 different locations or 16 different hospitals. Some question like that probably can be answered through cognitive search, right? Something like that. And any internal information becomes a fair game, right? Labs and electronic health records and notes and knowledge repositories and actual data, patient data, and their engagements with the hospital. All of it becomes a fair game where you have cognitive search that will give you an answer, which for a physician, it'll make physicians much more productive, because whatever you're searching for and all that can be fetched much easily with AI, and AI is there that could potentially help you. So I feel like this will only make doctors' futures much better. And I think that in US, at least, when I was with American Medical Association, one of the biggest aspects was physician burnout was a big issue, and tools like AI can only help with that physician burnout issue, because you have tools at your disposal that will hopefully make your job easier and hopefully give the information to you without you spending a lot of time or effort or energy, or all three of the above. The next question is, what is the best data file format that can be used in biomedical applications which can be encrypted properly? What is the best data file format? I mean, there's a lot of, there's encryption. I think it depends. I think that certain type of file formats you can. I mean, like if there are images, you cannot fit it into Excel or Word or maybe Word or whatever. But It depends on what the file is, and it can be reliably encrypted. It can be reliably be encrypted. There are a lot of, now we have very, very enhanced encryption technologies that you can use to achieve a very solid encryption. And I don't know if one is better over the other, unless it's something like a notepad or something. Then it's not where you want to be. But I think that with encryption, you should be able to achieve safe levels of encryption with most file formats. I'm guessing. I think that's the last question. I think I see. If I have not answered any question. Yeah, I think that's all I have. Questions.
Thank you, sir. On behalf of the organizing team, I extend our sincere gratitude to Mr. Sriram Pudukuchi for sharing his valuable insights and expertise with us. We also thank all the participants for your active participation. Kindly fill out the feedback form shared in the chat. Thank you all once again. Have a great day. Thank you, sir.
Thank you.
We will restart the next session within 5 minutes.
I think you can continue. Nagana sir is already online. Good morning, good afternoon, Nagana sir, Dr. Nagana sir.
Good afternoon, everyone. Now it's time to move to the second session of the Faculty Development Program organized by the Department of Artificial Intelligence and Data Science, Jyothi Engineering College. As we explore the growing influence of artificial intelligence in healthcare, it is equally important to understand the ethical responsibilities and challenges that come with it. Today's session is on the topic Ethics of AI in Healthcare. The session will highlight critical aspects such as patient data privacy and security, bias and fairness in AI models, accountability in AI driven decisions, the role of ethics in clinical and medical AI applications. Understanding these dimensions is essential to ensure that AI technologies are used responsibly and for the benefit of the society. It is pleasure to once again have with us our distinguished speaker, Dr. Naganna Chandraviraya. In our previous session, we had the opportunity to benefit from his valuable insights. And today, we have fortunate to continue this enriching journey with him. Dr. Naganna Chandraviraya is a highly accomplished medical professional with impressive credentials, including MD, MBA, CPE, CPHQ, CHCQM, and FACHE. He serves as a corporate medical director, denials management at HCA Incorporated. He is also an emergency room physician at Memorial Medical Center, Nebraska, USA. Today, he will be addressing a highly relevant and thought-provoking topic: ethics of AI in healthcare. As artificial intelligence continues to transform healthcare systems worldwide, understanding its ethical implications is crucial for researchers, practitioners, and educators. We are truly honored to have him back with us today. Without further delay, I invite Dr. Naganna Chandraviraya to take over the session.
Hi, good afternoon, everybody. Thank you so much, Anjali, for great introduction. I believe I still have the slide that needs to be run from the other side. Somehow my system is not allowing me to upload the slides. I still went through the same difficulty. Professor Sojan, if you could
Yeah.
kindly please.
No, I think my team will do that. I already engaged them. So they will do that. So let us take it. Maybe one
Sir,
of
we
you
will
please
share.
continue.
Please.
Yes, go ahead.
Okay.
Namaste, Swamiji, Siddhalinga Swamiji, Namaskar, Pranams to all Swamijis. Please go ahead.
Okay. Yeah. So today's talk is going to be more little bit cringe-worthy, let's say, the other way around. So we just heard a talk from Mr. Sriram about the non-communicable diseases and how the AI is going to be making an impact on reducing the cost of the healthcare, which is everybody's in mind. Next slide, please. So the biggest issue is the ethical issues. As we always say, the healthcare profession is a noble field. No matter whichever country you practice, wherever you go, they still treat with the highest standards. Where if we don't meet the highest standards, then there will be a lot of issues because healthcare is almost like an everybody's right, and also it has to be done right. So I did a lot of studies back in India as well as in the USA. As my teacher always used to say, knowledge is the power. The more you get, sometimes you become more nimble and understand the whole concept in a better, much larger way. Next slide, please. So just a background for people who are not here yesterday in the session. So I worked across several different healthcare systems, both small and big. I was a health inspector for the hospital to give a certification whether they can run the hospital in different departments like a stroke and heart attack centers. I also trained the doctors to be, the certified doctors here in the USA. I worked across 4 states to provide a care for the veterans here, which is a federal government. I currently work as a corporate medical director with the denial management, basically getting the money back into the system. They have about 192 hospitals across the US and one hospital in the United Kingdom. And that's the system that currently work as a corporate medical director. Next slide, please. The conflict of interest statement, I have no conflict of interest to report. I'm not representing the HCA, I'm not representing the Department of Veterans Affairs, and I'm not representing the Missouri Department of Health, where I previously served as a state inspector for the hospitals. Next slide, please. So we just heard from Sriram in the previous talk, and then after the talk I was thinking, oh my god, my topic is actually kind of into that, this non-communicable disease, NCDs, and then how that is going to be making an impact in the future. He was absolutely correct. We are excellent at episodic care. We are good when the patients come to the ER. As a ER physicians, we get so much of energies, like jump on and then do the right thing and make the patient turn around. And the patients turn around, we get kind of satisfaction. But that's how the system has been set up. That's how we spend a lot of money, a lot of resources, a lot of things. And one of the article that I was going through recently, this was published in 2025, 2024 end. This is from the CDC, Center for Disease Control. It's a well-written article about health equity and ethical consideration in using the AI in public health and medicine. As Sriram was talking about the public health, because that's where the crutch of this AI might make an impact. Of, I think yesterday in my talk I talked about the wearables, how all those things can be get integrated in the system, so that there's lot more feedback can given to the patients who has to participate in the healthcare delivery. Means it's a sustainable healthcare rather than episodic healthcare. You go to a hospital, you get a heart transplant, and then what are you going to do next? What are you supposed to do? So this article goes, if you guys get in a little bit of time, and whenever you can get into the slides, please read this article. It does gives a lot more information on the ethical issues of the AI in the healthcare, and what can happen and what should not happen. Next slide, please. So some of the concepts that we're going to talk in our discussion today will be about informed consent and the autonomy. Autonomy is sometimes we use loosely, especially in the United States, with liberty to choose what is best for you if you have a capacity to make the decision. Next one is the accountability and liability. Who is accountable for what, and then who is taking the liability for what, and then how the AI is going to append some of the things that has been traditionally done in the healthcare. Data privacy and security. Shriram did go a little bit about the secretive nature of the things that each and every company does that they don't want to reveal, but how they're going to be managing themselves with the data that they get, either confidential data from the patient or from the healthcare system and whatnot. And I think somebody asked very good questions about, can this the public health information or the information about the patient, I'm sorry, PHI, the patient's health information, how to make it more secure. And then he did give some feedback. It cannot be on an Excel sheet or in a notepad. Let's go through the algorithmic bias and the health inequality, which has been a big deal. I think this is a big thing that happens across all countries, whether it's a developed country, developing country, or underdeveloped country. This is a big thing with algorithmic bias and health inequity, and how a human and AI interactions and professionalism matters. And this is where the issue of, I think in my yesterday talk I was talking about a little bit about this ambient recording of the patient interaction with the patient. Some of the details can be cringeworthy, like only the patients wants only the doctor to have that information, no one else. How exactly that you as a professional physician or a medical care provider or a nurse anesthetist or a nurse helper, how do you protect that in a professional manner? And then the transparency and the black box issues, that there are certain things that should not be revealed. So currently, right now, we have the counseling in the mental health care cannot be revealed unless it is required by the law, wherein the discussion between the counselor, the psychiatric counselor, and the patient is only stays in that room, that is documented, unless it's a legal issue that cannot be spent cannot be spread outside. How does the AI recording all these things is going to interact with us? We're going to go through that one in a little bit detail. So our discussions will be based on these issues, that are the issues with the bias in the healthcare with the AI involvement. Next slide, please. So let's go back to the previous slide, and then maybe we can just elaborate a little bit before I get into the bias. Thank you, Anjali. So informed consent, I think one of the topics that I mentioned about yesterday, one of the big lawsuit in California. California is one of the big state in the US, one of the biggest one actually, and its GDP is so big as some of the European countries. In terms of informed consent, the California has a very, very strict rule that the provider has to have an informed consent for any recording that they do with the patient's interactions. Apparently, one of the provider, this is an allegation, obviously, that it has to go through the court system, that mentioned that the discussion between the patient and the provider was recorded, and the informed consent was never obtained. There is some looking back into the system, what happened, how it happened, things like that. But the bottom line is, unless if there is an informed consent, you cannot do any of those recording. What happens if the patient actually does not understand the informed consent? Patients come, want to see the doctor sits with them, and then it's like, is it okay if I want to record this discussion? I mean, obviously, when the doctor who has regarded as a higher authority in the discussion of medical decision making, sometimes they can be pushed to make it agree. And then if they says, nope, I don't want to agree for you to record, then the provider can say, okay, I can't see you today. Then what happens? So that's going to create a conflict between the patient's understanding of the informed consent, whether they need to really agree for it or not. And then what is the autonomy? What is the autonomy of the patient says, I don't want to be recorded, but I still want to get treated. I don't want all this discussion, everything. So obviously that's going to take a lot of time on the professionals to make sure that they can accommodate this one, accommodate and make some adjustment to the flow. I will say this again, healthcare is local and it is personal. You might see some celebrities going to a TV and says, "Oh yeah, I had a open heart attack. I got this," but most of the patients wants to keep the healthcare of their conditions private, and they would like to keep that way. What happens if you don't do that? When you take away that autonomy of spreading that information and making like a number rather than a patient, that's where the autonomy comes into play. Don't be surprised. This is going to be a big headache, even in the big countries like in China as well as in India, where the autonomy of the patients would be more regarded as a higher standard. Um, I think one of the issues with the accountability is also with the government regulations. How they're gonna hold who is responsible for the AI in the healthcare delivery of the patient's care. Next slide, please. We can go to the next slide, please. Thank you. Okay. So we probably heard about this one. So much of bias that gets into the AI. I think one person yesterday asked me a question. I think it's Dr. Prashant, if I'm not mistaken, about what gets into the system, which is called as a gigo problem. What is garbage in and garbage out. So when they create this, the AI infrastructure, basically the data infrastructure that puts in all the data, and the computer do algorithmic check, and then comes up with a plan and then spills it out, like what should happen, how it should happen. What if we have 1,000 white patients involved in a study and then the outcomes are different? What if we have 1,000 patients with no mixed race, that has, that does not, cannot be translated to a different population? What if it is not a mixed combination? That's why some of the healthcare studies nowadays are done all across the globe. And the idea is, what works in one ethnicity may not work in the other ethnicity. What works in the believe it or not, South Indians have a different kind of genes than the North Indians. That is a reality. And they tend to get the South Asians tend to get a higher diabetes mellitus compared to the other population. The one equivalent is the native Indians in the United States, where the genes tend to be of the similar pattern and they are at the high risk for developing diabetes. If you don't have that information added into the AI in the even before analysis, then it gets into the bias. Like, what was the study that was done that the AI is basing on in spilling out the outcomes, or this is what should happen to this patient, when it is not actually made for the whole population spectrum. It can create a hazard. So how does the buyer gets into the AI? Actually, as I mentioned, it is just through the data. The data from the Ethiopia about the management of diabetes can be a little bit different from a different country. The AI is just pulling the data from different sources, which is basically a cloud computing. How that's going to affect the one patient that you're actually treating, that is sitting in front of you? This is where the bias mitigation has to happen with the provider. Is this data really, that is the AI is spilling out, is really makes any difference for the patient that I'm taking care of, who is sitting in front of me, and I'm taking care of this patient? Will that makes a difference? So basically the data that come from all over the world, right? And there are different models. I think I gave some examples of.
ഓ ആ.
If you could kindly mute them, please.
Please kindly mute others, please.
നല്ല
Thank you. Okay. So basically the data sets can be different data. There is so much of data out there nowadays. And then, as I mentioned, the modeling also makes a difference. So as I mentioned, does this so much of information that is out there, does it makes it different for this set of population? This is where the professionalism from the provider has to happen. So if you look at some of the models that take in the aggregate model, algorithmic model, and then also stacking models, basically, then the question is, can you segregate up this data so much then it becomes irrelevant? In other words, what works for one population, say Indian population, does it work in the Caucasian population? Does it has to be modified or segmented out for a different population? Say in Papua New Guinea, in Australia, where they have a different set of genes, they have different conditions, that it has to be customized. It cannot be one size fits all model, and that's where the AI can get into the bias. It is not really just with all the information that they have, but can they predict? Is there any algorithmic way of putting that one? Say, for example, um, as I gave an example of Southeast Asians with their high risk for diabetes, can they modify this data? And when I say modify, that has to be extremely careful not to kind of tweak the data to make it look good or anything like that, but also that it works for that population. And then obviously the human interactions, right? So so in the United States, we see the patients all over the world, and then so many people speak so many different languages. What happens when they come into the interaction into the healthcare system where they need the care, and then the interactions can becomes fragmented out, and you get little bit biased data there from that patient that is put into the AI, and it can spill out a totally different outcomes or recommendation for that patient. This is how the it's not necessarily the architects or the person who created this the system, say in the example of spin theory AI, right? So they create all this data system in the background. Have they added all these points in place to mitigate the risk of this different human interactions, not just for one set of population? And then how do you mitigate this? You created all these models and everything. How do you mitigate that from for each segmented population? Again, it's not necessarily the architects or the engineers who have created this AI model for a particular set in the healthcare, whether it could be in the wearable, whether it could be an ambient technology, whether it could be in the audiovisual system, it could be in the robotics, but how they take the human interactions of different set of population and customize it so that it is actually applicable. Next slide, please. I think it is very important to know this you'll probably hear this way common than it should be, but this is what it is. The AI goes through this giga problem. Whatever the input that you have put in, the garbage in and garbage out is basically what it's gonna spill out for you. So if it does not have any good enough of data added up, I think one of the previous speaker, Sriram, was talking about this with the non-communicable diseases, that they work with the hospital, they get all the data about the from the patients, and they mingle, they do run the algorithmic in the background, and then come up with a plan. How do we move these patients who has diabetes from a stage 1 to stage 4? Say if they don't have any eye problem secondary to diabetes, how do you prevent it 5 to 10 years before it happens? That's where you save the money, right? If they don't get a heart attack, can you prevent that one ahead 5 years before? That's where you save the money. Or can you prevent the complication, or can you prolong the complication so that if the complications happens 20 years down the road rather than within the next 2 to 3 years? That's where you save the money. And then you can set up an incentive incentives that Sriram was mentioning about. How do you actually incentivize the patients so that they actually do follow through, either they're taking the medication, putting the wearables that they're supposed to be doing, and then also checking the blood pressure, checking the blood sugar, getting the screening done. All these things has to be done and all this thing has to be set up in the AI healthcare arena, where it is done right. If it is not done right, we're gonna go through the same problem with the bias and the mitigation problem that they had to go through. Next slide, please. So it has also created a lot of legal challenges, and some of the challenges includes laws and regulations to the pre-data and the development of the AI. Okay, also while different governments are trying to do different things with this AI, because it, as I think one of the slides that I showed you yesterday was how rapidly this AI is spreading across. Even though it was in a very nimble stage few years ago, all of a sudden it's expanded, and it is, in other words, it's kind of exploding even in the underdeveloped countries, places like like Kenya and sub-Saharan countries. It is happening so quickly. And then the question is, can each state government or each federal governments or each country government can put a lot of regulations around? Again, AI is crossing across the globe. So what happens in the Washington D.C. can also be happening in Thrissur in Kerala. It's the same technology that is transferable. Of course, it has to be modified, customized to the local population, but the data and information is about the same. How do you manage certain chronic conditions? So each country is trying to come up with how to mitigate this one. There are also here in the United States coming up with a role model of what are the criteria, certain criteria that the AI should follow. And then obviously there is a lot of lobbying which happens in every country, so that there won't be too many restrictions on them with the innovation that they do. But obviously it comes with public health. They will put some restrictions on certain XYZ. Recently, you saw some of um, the Facebook, and then this uh, the other the social media platforms held accountable for some of the suffering of some of the patients because of the mental health issue. This certain um, uh, uh, the websites were telling these mental health patients to do XYZ. Some lost life, some had to go through a little bit of more intense suffering, and then in the court of law, the jury of law in the United States held these companies accountable. If there are no proper rules that have been set up early on, we're going to go through these difficulties, and that's why a lot of the governments are trying to kind of struggling how to put so much of boundaries around the innovation, but also not to hinder the innovation. And we will talk about why we should not hinder the innovation in few minutes. Um, AI technologies, again, the solutions are varied. Again, different scenarios for different countries. So there are some constitutional, red flags which we mentioned about, that everything is not exactly the same. So some of the data that you might get from the United States are, may not be applicable for in Brazil or in Ethiopia or other countries. Um, so obviously, if you try to use this data, sometimes I will use this word vaguely. Some of the company, they will say, "Oh yeah, this has worked in this hospital, this hospital, and it will work here too." Administrators should scrutinize this one and say, what are the population there, what are the medical conditions that they had, how this has helped, whether it is something that can be transformative, or can it translate into the local healthcare system, which might be totally different in terms of the autonomy, in terms of the informed consent, in terms of the management because of the insurance coverage, and etc. Next slide, please. The other biggest ethical issue, I think I touched upon this part yesterday, was risk of de-skilling in medicine. Sriram used an excellent word. Doctors are good at providing the health care. You come to a doctor or a clinician. I use the word clinician in a vague manner because in different countries, everybody is not doctor. In other words, here in the United States, nurse practitioners are also called doctors. Physicians assistant are also called clinicians. Nurse practitioners are also called clinicians. Um, and the reason why they do is they actually do a pretty good job in managing the patient, because everything cannot be managed by the doctors because of the sheer volume of healthcare need. I do know in India they have a lot of restrictions with regarding to the licensing, that only the doctor can prescribe XYZ. They might open up some more avenue for the advanced nurses to do some practice. So it might change. The reason why I'm bringing this de-skilling in medicine is, if the AI does a lot of the XYZ work, then a lot of this provider is going to start depending on the AI to do certain things. And then once when you don't utilize your memory power, your training, your experience, and then you're going to lose them. And then this is one of the example that was actually proved beyond doubt, that the gastroenterologist who used to do a colonoscopy and figure out what was a polyp, which is not a severe cancerous, versus a cancerous tissue, and then they were given the AI enhanced help. Basically, the AI was helping them, looking up at the picture with the colonoscopy. Hey, this one looks serious. This one is not serious. This one is just a flat surface. Leave it alone. You don't have to do biopsy. So they get used to it. And then once when they take out the AI help, they went back and said, "You guys do it and see how you do." They actually failed. They started missing a lot of the lesions that they were supposed to be taking the biopsy. They were missing those. That is the de-skilling. This is one example. It could be even in the surgeon who does a hernia surgery, or a clinician who manages certain medical conditions. What if the AI comes into the not just the helping arena, but actually managing the patient's arena? Next slide, please. So is all the countries being on the same page with the advancement of the AI in healthcare? Different countries have different legal and ethical rules. Um, you might be surprised. One of the biggest AI growth is not actually in the United States, it's actually in China. They actually have a hospital which pretty much run by the robots. It is true and it is real. So, and in fact, they're building up a way advanced the AI facilities that where everything is pretty much done by the robots or the AI healthcare system. Patients is the only human there who get the treatment. They go there, get the medication, see the provider who is still an AI in a robot that manages all this, dispense the medication, and it's almost like a bunch of glass pieces and metal stuff and electronic items get into a Tesla factory. From the one end, on the other side, you have a nice Tesla car. Okay, it's just an example, but that's how they are built up. I was in China when I was doing my MBA, and I was so shocked that we went through like a factory that builds some of the Caterpillar, which is the very big equipment, farm equipment, and they make every 49 minutes. You go from one side of the entrance of the company, and then you come out with a joint farm equipment in 49 minutes. They can do it, and they are doing it. So the question is, will they follow the same rule as the other country? Or will it be the same thing in India, or will it be same thing in Kerala? Will that makes a difference with the different states and the countries having restrictions? And so in some country they can be way advanced, which can actually which can be challenging for the IT infrastructure, right? IT infrastructure is based on how fast you do things and whether you can put into implementation. So some of the big companies, they can be at disadvantage because of the government rules and regulations. They can do so much of experiment without oversight. So that's what I was trying to go with. I'm sure even in the other countries like European bloc have a different regulations. So also the African continent. Um, so some of these countries will go through the same difficulties whether this AI can do XYZ thing, and some of them will be winners and some of them will be just followers. Means they just have to utilize whatever the outcome that happens in a different continent. I do know that some of the AI has been put in place. I think a Professor Sojan mentioned about recently they did an hackathon in one of the AI department personnel went into some of the hospital and conducted some of the studies and the outcome to see whether it is applicable. It's at a local level. So that really tells me the AI is happening at the local level, not just at the big company level. Next slide, please. This is, I'm focusing a little bit more on in the United States. That's where I'm pretty much familiar with. I'm pretty sure there is a lot of with the new information. The government of India is also putting out a lot of new, not restrictions, but cautionary tales to be used by the AI companies when they do some research and automation and things like that. So some of the states, as I mentioned, um, something like the California is very restrictive, whereas certain states like Texas or Florida, they're less restrictive. And there are some Midwestern states that they would accommodate a lot of the AI to kind of get into the hospital, do certain things as an experiment, see the outcome. And there is a lot more regulation even in the European Union too, and other developed countries are going through the same thing. How to prevent the bias that was done at one country that cannot be translated to a different country because of the different subset, different language, different model, and different way of the healthcare. Um, Believe it or not, the allopathic medicine is big in India, so also the homeopathic medicine is also big in India. We all know that the Ayurvedic medicine, some of the home treatments, even in the state like in Kerala, so they all runs through. How does the AI is going to mitigate all those other systems, like whether it could be homeopathic or other system? How do they mitigate this one, taking that one into consideration rather than pushing only the allopathic the medical treatment? So different countries will have a different rules, and this is where the ethical issue comes into play, whether one size does it fits all or not. Next slide, please. I think I touched upon this one a little bit yesterday. What will happen if the AI can do a great job in reading the radiology? The CEO of the America's largest health in a public, this was recent, like what, maybe less than 3 weeks ago. This was a big news. Mitchell Quartz is a physician. He's a physician, and he's the president CEO of New York City Healthcare System. I did my training in Brooklyn, New York. I know about all the healthcare systems in New York. And I was actually trained in one of the New York healthcare system called the Woodall Hospital. So that's where I did my training as well in surgery. So if you look at this, the headlines like this, it is kind of scary. And then he says he's willing to replace all the radiologists and have only few radiologists to manage or sign off on the reading by the AI radiology report. So think about that. That's created a big storm. He backed down a little bit on his statement, but this is catching up. So what will happen with all these radiologists in the New York healthcare system, which several of hundreds of them, what will happen to them? Will they be absorbed into a different healthcare system? What happens if the other healthcare system also start using the AI and then they say, we don't need you? So think about that one. So it's not a done deal, but this is to think about the ethical issues or the moral issue. What are you going to do with this provider? What are you going to do with these nurses? What if the patient's nurses ratio in a hospital can be mitigated? Say, for example, currently in a critical intensive care unit, it's usually one nurse to one patient or one nurse to two patients. That's the maximum. Some places they can stretch it up to three, but they usually should be one to two. That's all they can handle in the intensive care unit. So what happens if the AI can come in and do a lot of the other administrative work, monitoring work? Can they make that into one nurse into four patients in the intensive care unit? Lot of saving for the human body. Then what happens to the nurses who are actually working there? So think about that. Yeah. Next slide, please. That is the societal problem. So I think Shriram in the earlier talk mentioned, and I think I mentioned in my talk yesterday about the human loop, wherein if the AI gets everything done right about half of the time, nobody is going to use it. That's not going to happen. If the AI does everything 99.99%, then everybody is going to go on AI, then there will be some replacement or displacement of the physician. But everybody is battling for the middle ground, which is 70 to 90% of the time the AI is accurate, and the clinician or the physician or the doctors is going to be managing that one, make sure that it is actually done right. This is where my previous talk information about professionalism comes into play. Professionalism means using the highest standards only based on what is best for the patient, not what is best for the system or what is not best for the doctor, but what is best for the patient alone. Next slide, please. So again, I think I gave talk yesterday about some of the issues with the artificial intelligence, what impact that will have it on the patients. That's the most important. We are talking about the patient. Even though I'm a doctor, I am also a patient when I seek a medical care. It's the same thing across because we are all human. We all have healthcare needs. We are all patients at one point or the other. Um, Again, there is a lot of uncertainty with AI, but when there is uncertainty, there is an opportunity specifically for the people. This is in light to the Jyothi Engineering College with an artificial intelligence department where they put a lot of these ethical issues into play or consideration before they spill out, before they train the new engineering students about the ethical issues to be considered when they're developing a new model or a new care delivery model, how this has to be put into place. There is so much of opportunity out there, not just in developed countries. A lot of underdeveloped countries are coming up with a very exponential rule. There is a lot of opportunity for the engineering student to thrive in this AI arena in the healthcare. I'm sure there is so many other departments that they can get into, but the AI is a big one because it's a big gorilla in the room because of so much of money that has been spent on this one. Next slide, please. I would welcome any questions or any comments. So this has been a great session, and I would like to thank Jyothi Engineering College and Professor Sojan and the excellent team that have really accommodated for this discussion, and then helping me listening to the other speakers about what their role that they're doing, and some of the people who ask me questions actually make me think more and see how to seek more answers. Thank you.
Thank you, sir, for the insightful session. We will now open the floor for questions. Dear participants, you can now interact with the resource person.
Good afternoon, sir. Hello.
Good afternoon. Yep.
This is Mahmood Khan. I am a PhD research scholar, sir, in Aditya University. My research was is on artificial intelligence in healthcare, sir. Actually, it was. I was taking actually submitted a conference paper, and my thing was, sir, I used only the Kaggle data set. Sir. If I went for any hospital, they are concerning about the patient data. How can we in future? How can we get to the real data, and how can we my model inside?
I can speak what we do in the United States. I do know different local have different jurisdictions about the laws there. I cannot speak about that, but I can speak about what happens in the United States. Every hospital has what you call as an institutional review board, or IRB. Institutional review board basically gives has an authority to approve for any what you call as a non-patient healthcare information. Means it can be codified, it can be modified, it can be decoded, so that you take away a lot of the patient's real name, patient date of birth, and the patient's social security number, and then spill out everything else. Example: patient A, 45-year-old with diabetes, blood pressure, hypertension, had a heart attack on this day. That is not identifiable to that patient. So they can decode it. Okay, and there is a way to do it. I mean, it's it's a pretty simple mechanism. So they can get all the data, all the information. The only time that the institutional review board does not get into is if this sharing of the patient's information is for payment purpose. So the insurance company get all the information. So if there is any the drug company that is sponsoring any of the studies on the patient population, they can get all the information. If it is due to the management of the patients within the hospital, all the doctors, they can share the patient's information on. So if it has to go outside for an entity, say the way that you are mentioning, it has to be decoded and it has to be approved by what I call as an institutional review board. They can share you the data. It's no big deal. I do not know what are the rules and regulations in the local area where you are approaching the hospital. I'm pretty sure they also have a system set up so that they can share the information about the healthcare issue of patients, but they don't have to give you the name of the patient, their date of birth, or the Aadhaar card number, or some of those. So they can decodify it and they can work with you on that.
Thank you, sir.
So there is a question in chat box that is like Google has access to all searching data. Do AI tools have access to searching and uploading data?
Oh, this is an excellent question. So believe it or not, so the doctors, also depend on some of the AI technology. And in the past, we used to use something like Hippocrates. Hippocrates was a famous like an app that has all the information about all the medication that has been approved by the Food and Drug Administration in the United States. It also has some medical information or the medication that are not approved, but it can be used as an experimental drug or something like that. So we use that because sometimes we come across a patient who has a different type of cancer, and all of a sudden it's like, oh my God, I remember this cancer that I was taking care when I was in training in 2000. Now this patient is here. I had to provide the care. So then we look up that information and say if it is accurate. So there is now a new one called open evidence. Open evidence is a online platform for mostly used by the doctors. Of course, anybody can use it. They can go in. You had to register, and I believe here in the United States, you had to give what we call as a NPI number. That is called National Provider Identification Number, just like Aadhaar card number back in India for everybody. So, are the license sure that you get in India? So here they call us an NPI. So you had to enter your NPI number to access to that open evidence, which basically has all the journals out there, all the medical journals, and they will synthesize all the information and spit it out for you. Means in the New England Journal of Medicine, this was the article mentioned about this disease on this day, and this is what happened in the British Journal of Medicine that talked about this condition, and these were all the treatment options. It actually helps us to kind of clarify with some of the things that we knew or did not know, but you had to provide the care to the patients right there and then. That has been a very good tool for us. Open evidence. um, just like that, there is also Chat GPT, but I don't think the patients or the providers can upload the data. You can only download, just like what the question was. You do the Google search and you find out who is the best doctor, best thing, or whatever the question you have. You can ask those, but you cannot upload anything. So I hope that clarifies. But we as a provider use open evidence as a best source to make some determinations in the medical delivery. Thank you. Yes.
So there is another question. How AI can be used to treat as well as manage the brain signals to autism as well as specially challenged patients?
So this is where the bias comes into play. The bias about the patients, a marginalized patients who can be mentally challenged, patients with autism or a developmental delay. Those are the patients that has to have a special emphasis in the AI. There is not a whole lot of room for that one. Or not has been done in a significant way. And this is where the professionalism really matters. The doctor or the clinician who is taking care of the patient, making sure that it is what is right for that patient. Um, I believe that the AI is, some of the platforms are creating some kind of exceptional way of managing some of these patients in a population, in the data set. Say, for example, patient has diabetes, blood pressure, heart condition. Oh, by the way, they also have an autism disorder. How is the management is going to be tailored to that one versus a general population? So they are coming up with some new innovative way to mitigate that one. It is a structural issue that needs to be tweaked on the AI side that they can come up with, and I'm pretty sure we will have a good answers to that one. Thank you. That was an excellent question. Any other questions, Anjali?
No, no. Sir, okay. Respond another question. Algorithmic bias is a threat in clinical AI tools. How does regulation help in this to tackle it? Because cybersecurity and data privacy problems create from this. Do we need
Yeah.
AI to check all the algorithms the user feeds for AI tools? Can a AI check possible in backend tools?
Yes, the answer is yes. In fact, so some of the advancement that has happened either with the Chat GPT or with the Google Gemini, or any of those, they have all kind of data that has been kind of fragmented. This algorithm is not new. This has happened with the Facebook, Meta, TikTok, you name it. Any of them, pretty much YouTube, they all use the algorithmic way of mitigating. So also in the healthcare, unfortunately, that is the reality, which is basically saying, I think our previous speaker, Mr. Sriram, was talking about the algorithm of, can we put these patients who has no diabetes, which is pre-diabetes, what are the things that you need to do, which is basically an algorithm way of sorting out to see how do we prevent this patient from getting diabetes in 5 years or 10 years. Can we do some mitigation early on? That is algorithm. Now, only the patient's health informations can be kept private. I do know that there are some, the data breaches that has happened, and I'm not, I'm not ready to say that everything is going to be perfect in secrecy. That is impossible to expect, because as long as the patient's private information, health information is kept away from the public domain, they might be able to do this algorithm, and they will continue to do it no matter what we do. um, Even the governments have a difficulty to prevent them from doing this algorithmic management in stratifying the different population. So there is always a case to be made whether they should really get into the healthcare or not. But the train has left the station already. I mean, so many healthcare systems are already using the AI healthcare, and it will only continue to get more progressive. I hope that has helped the question, because we really can't prevent this algorithmic modeling in the AI anymore. It has gone beyond outside the boundaries.
So there is another question. We have so many open AI tools currently available in the world. How do you how you choose a particular AI tool for a specific course?
This is probably a great question for the developers who are really intelligent in this one. I am more focused on what is used in the healthcare arena, where it actually makes an impact. I think in my yesterday talk, I talk about so many different the AI platform used by different hospitals. This is where the problem that I think, um, I use that word, when there is uncertainty, there is an opportunity. That means if so many people are doing different thing, one big person who has a big idea can get all these things together and make it big. Give you an example. Electronic health record went through the same thing in the United States. There are so many electronic health records, it's like wazoo of them. But there are three or four that are really standing out. One is an Epic, another one is a Cerner, another one is an Allscript. I have used about 6 electronic health medical system, and I'm fluent in all of them. But over the last 28 years, I have used so many of them. These four stand out good. And then for the healthcare need, it basically depends on what you're looking for. If you're looking for a wearable, then it's a different AI setup. If you're looking for an ambient technology, it's a different setup. You might ask, will that not increase the cost? Yes, that is a sunk cost that you had to put it in place. There might be a different platform that can provide the full continuum of care the AI can provide. And there are a lot of new startups are coming up with this, from the encounter of the patient all the way till the management, not just in the hospital, but even outside. This whole spectrum will be just in one AI in a platform. Different people are giving different input because that's where the money is. But at some point, it's gonna kind of what you call as a horizontally get expanded into one or two big healthcare AI platforms to say. That's an excellent question. Again, so much of startup putting so much of money right now is because everybody is trying to experiment what is gonna stick. In other words, um, uh, I use term vaguely. Sometimes when there is a lot of lawsuits, right? You take it to the lawyers, and the lawyers will throw it to the wall, and they'll say, "See which one sticks," right? So that's why so much of money is spent in the AI to see which one will come out better as a product that actually make an impact for the patient. Right now, it is an investment. The return on investment is seen in very few of them, but some of them are still struggling. I hope that answered the question. Thank you.
Dear participants, if you have more questions, you can ask it now.
Again, if I don't give a correct answer, there is an excellent panel of the speakers that's going to come on the stage, within today and tomorrow, day after tomorrow. My friend Dr. Vinay, he has a lot of information about the data set. He's actually doing a studies on the AI. Believe it or not, he has so many fellowships. He's a ER doctor. He's a pediatric doctor. He has done a nephrology fellowship. He has a ER done fellowship, and he's doing an AI. He's like a knowledge guy. He will have a lot more answers in that data health set, how it is used, how it can be integrated. You will hear his talk. He will have some answers on some of the questions that I might have not able to answer. Thank you.
Thank you, sir. On behalf of the organizing team, I extend our heartfelt gratitude to Dr. Naganna Chandraviraya for sharing his valuable insight on such an important topic. We also thank all participants for your active involvement. Dear participant, kindly fill out the feedback form shared in the chat box. Thank you. Thank you all. Have a great day ahead. Thank you all.
Thank you all. Yep.
Thank you, sir.